We know the ultra-safe nature of ABiC eye track. We've heard about the multiple mechanisms of action both in the proximal system and the distal system. But I want to have an honest discussion about what are the barriers for adoption, misconceptions and barriers of ABiC out there. We've been using it, but what about our colleagues? What are the barriers that you see, and how do you address those barriers, whether they're technical or from understanding perspective or patient indications? What have you experienced?
I think in general, if somebody's not MIGS trained at this point, it's the natural barrier that any new surgeon has at really manipulating devices within the angle, obtaining their view of that nasal angle with intraoperative gonioscopy. But if they're already MIGS trained, I think that the actual barrier that they have is going to be minimal. There's going to be a limited learning curve for these docs because they're already in the angle. I think that really the most difficult portion of the procedure is intubation of the canal, the initial intubation. Because once the catheter is in the canal itself, it's very easy to thread that catheter through the canal. But if a doc is already experienced in MIGS, it's really not that difficult for them to achieve success with this procedure.
I probably was the last of this group to adopt ABiC eye track, and I think it's right. It maybe seems a little bit intimidating, but actually, not only was it fun to adopt, but it was enjoyable, and I felt the thrill of actually doing surgery on the canal rather than just kind of putting things in it, sort of one simple shot. And what impressed me was the level of confidence you have during the procedure that you're achieving the anatomical goal. And for the canal, I think that that's a common area, where people aren't quite sure that they're where they want to be, and this solves that problem 100%. So surprisingly for me, I probably felt more confident that I had achieved my surgical goal after my first procedure doing this than I had ever felt with a trabecular meshwork procedure, because it was just so clear that the anatomy was literally lighting up as that catheter went around in a circle. It was fun, and what I guess I would say is, why did I wait so long? I would say, though, there is, it's very difficult for us to change practice patterns. I mean, you have to get up, you have to make a phone call, you have to find out who your rep is, you have to talk to a colleague who's been doing it. I mean, if you and I operated in the same OR, I'm sure I would have adopted it a long time ago. So, however, once you get the ball rolling, it's easy to do this. And, I guess if there's a lesson learned for me, it's, no need to wait. I also had some misconceptions. I thought that there was a big device you had to buy that illuminated the catheter. I didn't realize that that was easily obtainable with your first case without a capital investment. So, some misperceptions that were fortunately corrected, and now I get to be here with you guys.
So tell me then, how does ABiC eye track compare to the other MIGS out there, and a lot of MIGS out there now? How does it compare, and where does it fit compared to other things that we have?
Well, I think other MIGS are, a lot of the other MIGS are actually device, so a stent, and it usually bypasses where the site of, the thought of where the site is, where it's obstructed. So, for example, eye stents would bypass a diseased trabecular meshwork, bypass a suprachoroidal device. And so with ABiC, there's no actual device you're putting in the eye. You're using the probe, the catheter, to go around canal, and like Nate so well put it, you're actually seeing exactly where you're at. So there's no guessing game. That's a big thing for me. I'm a belt and suspender type guy. If I think the disease process is somewhere along the line from TM to distally, it's nice to know that you're in that area that you want to treat, as opposed to a guessing game.
Mm-hmm. And then as far as effectiveness, I thought it was interesting that yesterday during the is trabeculectomy dead, yes, no discussion, that Dr. Reed put up multiple slides that compared trabeculectomy to all of the available alternative procedures. And the only two procedures that came close to trabeculectomy were glaucoma drainage devices and canaloplasty. Now granted, that was ab externo canaloplasty, but the work that you've done has indicated, and both of you, has indicated that the ab interno, so the eye track ABiC, is quite close to what we can expect from the ab externo canaloplasty. So it's not a direct comparison among all of the players, but it's certainly suggestive that eye track ABiC maybe a bit more effective than the options that we have that are not, destructive or involve
So-
an ABiC sternum procedure.
So Paul, we gave you the big mic because you have a lot of big thoughts, but what's the typical patient profile that you see and you perform ABiC eye track with?
Well, I think what the beauty of the device or the procedure is that there's a large population of patients who could benefit from the procedure. It's not just a patient who's fake. It can be a procedure, pseudophakia at the time of cataract surgery. And I think one of the nice things about it can be for mild to moderate and even actually advanced disease as well. I've done it on patients even post-trabeculectomy. So I find that the selection of patients is very broad. And so for anybody who I feel like I want to really manage the natural outflow system, this is a very universal procedure for that patient. And I think, going back to your data, I think what's really interesting is that it worked well for both of your data, rather. It worked very well for the standalone as well as with the cataract surgery as well, and different types of population of patients. For those who had starting pressures that were higher or starting pressures that were in the middle to upper teens, you still had a significant reduction that was maintained. So I think the responder rate part of it is really what excites me, meaning, as you said earlier, you don't know where the resistance to outflow is preoperatively. Is it TM, Schlemm's, or distal? And so yes, some devices may work on specific sections of the outflow system, but because this has multiple mechanisms, you're kind of hedging your bets, so you have a better chance, in my opinion, of getting that reduction of pressure depending on the type of patient population. So for me, it's kind of across the board. As long as I have a good angle and I can see the angle very well, I think they're a good candidate for ABiC.